Good evening, everyone, and welcome to this very scary, spooky topic of our discussion tonight. Actually, this is all inspired by a conversation that I had with my grandmother, kind of the theme, because she always said that it's so fitting that you start talking to her about this around Halloween because she's scared to answer her phone. So, getting the calls about Advantage plans and signing up and everything. So we figured a lot of people at AnCan had the exact same feeling. So that's what we're going to talk about tonight. So of course, as always, being your own best advocate means taking whatever you learn from us and taking it to your provider's office. And we, of course, would like to thank our sponsors, Bayer, Pfizer Oncology, Myovant Sciences, Foundation Medicine, Myriad Genetics, Janssen, Johnson & Johnson, Telix, and Blue Earth Diagnostics. And on a very, very special note tonight, we want to give a big thank you to Triage Cancer, who we are doing this webinar tonight with. And I especially would like to thank our very special volunteers at AnCan. I was out all last week due to my fiance being hospitalized and a medical issue of my own. So we could not do any of this without them. And with that, I'm going to call up Rick Davis to introduce this webinar, give us a little outline, and tell you a little bit about AnCan.
Good evening, everybody, and it's a pleasure again for me to be here with you. The webinar tonight is a webinar that I felt we've needed for several years because I'm on Medicare, and every time I have to think about renewing my Medicare, I get very, very scared. So we know that this is a scary proposition for everybody, and many of us bury our heads in the sand. And so we hope that we're going to make things a little less scary tonight. For those of you who don't know, AnCan Foundation provides all kinds of patient support, patient navigation, even a bunch of advocacy, and of course, a lot of education. And so we're here tonight as part of the education, but we encourage all of you to check us out at ancan.org, ACANCAN.org, ancan.org, and look at some of the events we have each month. We run about 20 to 30 live support and educational events each month, and we welcome all of you. All our program is free, and everything except the webinars are drop-in, so you don't have to register. But because of this platform, we need you to register for the webinars. I am delighted to welcome two experts. Our partner is Triage Cancer, who are a simply amazing outfit. They are the nonprofit experts on all kinds of benefits, insurance, healthcare, financial assistance. I can't say enough good things about them because they help so many people, and like us, they are a nonprofit, triagecancer.org. And representing them is one of their staff attorneys, Amanda Goodstadt, and we are delighted to have her with us and to present for the first 20 to 30 minutes or so, and then we'll be taking all your questions to try and resolve all the problems. One of the people—
And Rick, I'm so sorry, I forgot to mention that you can at any time put your questions in the questions pane, at any time.
Yes, so put your questions in the question pane. Thank you, Alexa. The other expert is my own Medicare broker, who has helped me and got me to the right plan that has worked for the last few years very well. So, and more than that, Kim Umphres, who's based in Tucson, has been incredibly generous with his time. Anytime we've had an AnCan person who's had a Medicare issue, even in states where he doesn't write, and he writes in 13 or 14 states, so he covers a good part of the country, but that has got nothing to do with his willingness to help us, and we are truly grateful. So I think with that, I'm going to turn the platform over to Amanda to start her presentation.
Thank you, Rick, for that very kind introduction. I am just going to, bear with me. I'm going to hopefully get my slides to work very quickly.
It's perfect, Amanda. You're good to go.
Awesome. Okay. So thank you very much. I am excited to be here with all of you to talk about Medicare on this spooky Halloween Eve. It is my hope that after tonight's program, people will feel a little less scared talking about Medicare. So for anybody not familiar with Triage Cancer, we are a national nonprofit and we provide free education on legal and practical issues that can impact people who've been diagnosed with cancer and their caregivers. But to be totally honest, the vast majority of the things we talk to people about are just as applicable to someone with another kind of diagnosis, with any other chronic health condition or disability, or frankly, someone who's generally healthy but just wants to learn more about things like health insurance and Medicare. So Medicare is obviously the public health insurance program that is available for US citizens and certain legal residents who are either 65 and older, or who've been receiving Social Security disability insurance benefits for at least 2 years, or who have end-stage renal disease or ALS. Medicare is a complex program, and half an hour is honestly not a lot of time to talk about it. So my goal tonight is to hit some highlights, and then towards the end, tell you where you can go if you want to get more in-depth information. One of the first things everyone wants to know about when we talk about Medicare is what's it going to cost? And it's important when we talk about the cost of any health insurance to understand certain basic terms. These are terms used whether you have employer-sponsored insurance or Medicare or a marketplace plan. So I want to make sure we're all on the same page about them. First, there's the cost just to have health insurance at all. That's your premium. A fixed dollar amount you are paying every month, whether you are spending all your time at the doctor's office or whether you don't see a doctor all year. Then there are costs when you actually go and use your health insurance. First of those is a deductible. Again, a fixed dollar amount that you are responsible for paying out of your own pocket before your insurance plan kicks in and starts to share costs with you. Deductibles can be very high. They can also be really low or even zero. A plan with a $0 deductible is going to start sharing costs immediately on day one. Then there's a cost each time you actually go and get care, each time you see a doctor, each time you get a lab test, each time you fill a prescription. That kind of cost can be expressed in one of two ways, either as a fixed dollar amount, in which case it's a copayment, or as a percentage, in which case it's a coinsurance or cost share. If every time I see my doctor, I pay $20, that's a copayment. If every time I see my doctor, I pay 20% of the cost of the visit, that's a coinsurance. And then the final cost-related term I want to make sure we're all on the same page about is out-of-pocket maximum. Again, a fixed dollar amount. Once someone reaches their plan's out-of-pocket maximum, their plan is going to take over and pay 100% of their covered costs for the rest of the plan year. To figure out what your out-of-pocket maximum is, you have to look at your plan, both to figure out the dollar amount, but also to know what kinds of expenses are included in trying to satisfy it. Okay, so now we have these basic terms under our belt. Medicare is divided into different parts, so I want to cover all these different parts and share something about what's included in each part and what each part costs. Medicare Part A is what I'm going to refer to as hospital insurance. This is the part of Medicare that pays when you have to go into the hospital, when you have to be in a skilled nursing facility. It covers very limited nursing home care, and it is also the part of Medicare that is where you find hospice benefits. Generally speaking, if you have worked and paid into the Social Security system, Part A is premium free, meaning there is no cost each month just to have it. If you haven't worked and paid into Social Security, or you've worked but not long enough, you can still get Part A, but you're going to have to pay a premium to have it. And the amount is going to depend on how much work history you do have. But even though for most people there's no premium for Part A, there are other costs. So Part A has a deductible. Next year, that is going to be $1,632 per benefit period. So Part A's deductible is a little bit different from most health insurance deductibles. Most of them work on a calendar year basis. For Part A, the deductible is per benefit period. A benefit period starts the day someone is admitted to a hospital or to a skilled nursing facility, and it ends when that person hasn't been getting any inpatient care for 60 days in a row. So for someone who's got a serious health condition, something like a cancer diagnosis, it's possible that in the course of one calendar year, they could experience more than one benefit period and be responsible for more than one deductible. And then there are also payments for Medicare Part A based on how many days someone has been an inpatient in a hospital or a skilled nursing facility. For people who have to pay a premium for Part A, if they don't enroll when Medicare believes they are first eligible to do that, they may have what's called a late enrollment penalty. And in the case of Part A, that is a 10% increase in your premium for twice the number of years that you were eligible to have Part A but didn't sign up. But again, that's only if you are someone who has to pay a premium for Part A. Medicare Part B is what most of us think of as medical insurance. This is the part of Medicare that is going to cover going to a doctor. It's going to cover preventive care, outpatient care, lab tests, physical therapy, occupational therapy. All of those types of services are covered under Part B. Even if you have the work history to get Part A premium free, Part B has a premium. For most people next year, the premium is going to be $174.70 a month. I say most people because if you are considered to be high income by Medicare, you will pay more. Part B also has a deductible. Next year, it's going to be $240, and it operates as a cost share. Medicare pays 80% of services. You are responsible for paying 20% out of your pocket. Unlike most employer-sponsored health insurance and marketplace plans, there is no out-of-pocket maximum. So costs can get pretty high if you need a lot of medical care. I'm going to talk about some ways to reduce those costs. Part B, just like premium Part A, has a late enrollment penalty. If you don't sign up when you are first eligible, you have a 10% penalty tacked onto your premium for each full 12-month period that you were eligible to have Part B but didn't sign up. And that premium, that late enrollment penalty stays with you for life, with very limited exceptions. Medicare Parts A and B together are what people refer to as original Medicare, or sometimes traditional Medicare. This was all of Medicare that existed back in 1965 when President Johnson signed it into law. It is a fee-for-service program, meaning there are no networks of providers. If you have original Medicare, you can see any doctor or be treated at any hospital anywhere in the United States, so long as that provider accepts Medicare. I'm going to skip Part C for a moment. I'm going to come back to it, but I'm going to skip over to Medicare Part D, which is Medicare's prescription drug benefit. Part D became effective in 2006. Between 1965 and 2006, Medicare did not provide any drug coverage. Part D is made up entirely of plans from private insurance companies. Each of these plans sets its own premium. The plans can have deductibles, but the highest deductible a plan can have next year is $545. But there are plans that have no deductible and anything in between. And plans, co-payment structures, and co-insurance structures are going to vary They differ by plan. They also differ depending on what drugs you need. So two people, like you and your spouse, could have the exact same Part D plan, but have it cost each of you a different amount of money unless you take the exact same drugs and the exact same dosage of those drugs. Part D, just like the other parts I went through, has a late enrollment penalty if you don't sign up when you're first eligible and you don't have what's called creditable coverage. That means coverage at least as good as what Medicare offers. Medicare has all these rules about that. But if you have a question about whether or not other insurance you have is creditable for purposes of Medicare, you can call your plan to find out. A couple of terms just to make sure we're all on the same page about when it comes to looking at prescription drug coverage. The first is formulary, just a fancy way of saying the list of drugs your plan covers. Formularies are broken up into different levels or payment tiers based on how much the insurance is going to contribute towards your costs. Lower numbered tiers are where you find your cheaper drugs like generics and your lowest copayments. Higher tiers or the highest tier is where you're going to find things like specialty drugs and in all likelihood a coinsurance amount. It's important to understand if you go to fill a prescription for a drug that's not on a plan's formulary, you're responsible for 100% of the cost, and whatever you pay is not going to count towards satisfying a deductible. I just quickly want to show you what does drug coverage look like under Medicare Part D next year. So the first thing someone's going to pay is their deductible, if there is one. Once they've satisfied their deductible, they're going to enter what we're going to call initial coverage. And during this phase, you are paying 25% of the cost of your prescription drugs, and the remainder is being covered. That continues unless and until your total out-of-pocket drug costs will hit $8,000. If you are in need of drugs and the drug spending hits $8,000, you enter a phase called catastrophic coverage. And beginning next year, when you enter that phase, you will no longer have to pay anything for your drugs. It will be covered 100%. I also just want to note that when I say total out-of-pocket drug costs, that doesn't mean that you yourself have paid $8,000. Total out-of-pocket costs include things like payments that are made on your behalf, for example, drug company discounts. The reason there is no longer any payment that you have to make during catastrophic coverage was the passage last year of the Inflation Reduction Act. So those of you who are on Medicare right now may be ready to say, hey, wait a minute, right now in catastrophic coverage, I still am responsible for 5% of my drug costs. That's true. The Inflation Reduction Act brought about this change that is beginning January 1. Beginning in January of 2025, there's an even more consumer-friendly change coming. There's going to be an out-of-pocket cap on drug costs of $2,000. That cap is going to apply whether you have a standalone or whether you have your drug coverage through a Medicare Advantage plan, and I'm going to get to that in just a moment. If your plan has a deductible, whatever you're paying for that deductible is going to count towards reaching that $2,000 cap. But understand that the $2,000 number is expected to increase over time. Another big change coming in 2025 is that if you have a big payment for drugs, if, for example, you're on a super expensive drug and you're going to hit that $2,000 cap in January, you're not going to have to pay all of it in January. You're going to be able to spread out payments evenly over the course of the year. There's a lot of details still being worked out in terms of how that's going to be in practice. Okay, I talked about Part A, hospital coverage, Part B, medical insurance, Part D, drug coverage. I skipped Part C. Part C is the Medicare Advantage program. It's an alternative to original Medicare. These are managed care plans sold by private insurance companies that are bundling together all the services you would otherwise be getting under Parts A and B, and the vast majority also include drug coverage. And they work very similarly to marketplace plans or employer-sponsored plans that people are used to. The plans can be structured in a few different ways, but the most popular are HMOs and PPOs. Each of these plans will have a specific network of providers, and each of these plans will have its own costs. So there will be variable premiums and deductibles and cost sharing. Two things I just want to highlight about Medicare Advantage plans. The first is you still have to pay your Part B premium. Even if you are seeing an ad right now or getting a phone call about a $0 premium Medicare Advantage plan, that just means there's no Part C premium. You still have a Part B premium. The other thing I want to highlight is, in contrast to original Medicare, these plans have an out-of-pocket maximum. They're required to. And the highest out-of-pocket maximum an Advantage plan can have next year for in-network services is $8,850. Just to highlight how many choices people have with Medicare Advantage, this year, there are around 4,000 of these plans across the country. On average, people are choosing among anywhere from 40 to 45 plans. There's a county I read about in Ohio, I think it's the highest number of plans. They have 87 plans to choose among. And even though there are all these plans, the market is dominated by just a couple of insurers. A quick review, since the most popular types of these plans are HMOs and PPOs, I just want to remind people of some of the key differences. An HMO is going to have a smaller network of providers. They're going to typically require that you select a primary care physician and get referrals to see specialists. PPO is going to have a bigger network of providers and likely provide some out-of-network coverage, but it's not going to require a primary care physician or referrals for most things. The trade-off, though, is that PPOs do tend to be more expensive. So how do you go about comparing these plans when there are so many of them? I wanted to just say a word about how to calculate total costs of a plan. I've been working in the Medicare world for a long time now, and one thing I've noticed kind of consistently is people's desire to look at premiums in terms of, figuring out what something's going to cost. And I totally understand that, right? People understand that premiums are fixed costs. They know they're going to have to pay them each month. A lot of people do their budgets on a monthly basis, so it's easy to get their arms around the idea of, well, here's what my spending is going to be on healthcare. But for someone who has a serious health condition and expects to use a lot of healthcare, it's really only going to tell you, or the premium's only going to tell you a piece of the story, right? On my slide with terms related to what health insurance costs, that was only one of the terms. We feel at Triage Cancer that the best way to calculate total costs of a plan is to consider both premiums and that plan's out-of-pocket maximum. So just as an example, I created these two plans. In each case, you're going to have to pay your Part B premium. The first plan is a zero premium plan, which seems awesome, right? Because maybe you're going to get some other benefits for no additional monthly charge. And that first plan has the maximum out-of-pocket that's allowable for next year. And then the second plan does have a Part C premium, but a slightly lower out-of-pocket maximum. Once we do the math, something interesting happens, right? When we total out 12 months worth of the Part B premium plus 12 months worth of each Part C premium, plus the out-of-pocket maximum for these plans, the first plan that had no additional premium totals out just shy of $11,000 for the year, but the second plan totals out at just shy of $9,000, a $2,000 difference just from doing one math equation. And we actually developed, we have a Medicare plan comparison worksheet that can help walk you through this, as well as some of the other elements of Medicare, and I'll show you how to access that in just a minute. Comparing costs, though, is only one step of comparing plans. There are other differences between plans, right? So the second major step is looking at the different networks and making sure that any providers that you want to stay with are covered by the plan you're selecting. And then the third big category of comparison is prescription drug coverage. Are the drugs you need covered at a price you can afford? And in addition, are there any restrictions a plan is placing on your drugs? So a drug can be on a plan's formulary, but that plan can still tell you there are quantity limits, or that you are going to need prior authorization, or that there are step therapy requirements. As with anything, Medicare Advantage plans have pros and cons, and everyone's going to come out with a different sort of decision about whether one of these plans makes sense for them. To me, some of the most significant pros are the stated out-of-pocket maximum and the fact that Medicare Advantage plans can offer some benefits that original Medicare does not. For example, some of the biggies are coverage for routine dental care, vision care, hearing care. Those are the pros. There are cons as well, though. And to me, one of the most significant cons, or maybe the most significant con, is you're going to be limited to a network of providers. And you have to make sure that any providers you want to see are in a plan, but also think about the fact that you may not know today about a provider that you're going to want to see in 6 months. One last category of the sort of basic Medicare landscape are Medigap plans, or Medicare supplemental plans. These are private insurance plans that someone can purchase that help to pay out-of-pocket costs from Medicare Parts A and B. So again, original Medicare has no out-of-pocket maximum the way Medicare Advantage does. So this is one way to deal with that fact. Medigap plans are sold all by private insurance companies, and even though Medigap is a program through Medicare, which is a federal program, exists in all 50 states, there are differences in Medigaps from state to state. So it is very important, if you are talking to friends, family members, fellow support group members, and they are telling you about things related to Medigap, that what is true of Medigap in one state may not necessarily be true of it in another. Very briefly, the vast majority of states standardize their Medigap policies using the letters A through N, although you'll see a few of them are missing, they've been retired. I know that this is super confusing because the A, B, C, and D on this slide have nothing to do with the A, B, C, and D that I told you about previously. These are just letters that are designed to tell you a specific kind of Medigap plan. And every Medigap that has the letter attached to it, like any Medigap that's a plan A, has to offer the exact same medical benefits that are listed in this chart. So that when you are looking and you're comparison shopping, you might see two different plan Gs, one that costs twice as much as another. But despite that, they both still have to offer the same basic benefits that you see in this chart at the percentages shown in the chart. So basically, you are paying another premium for another insurance plan, but that can save you money because by paying for that insurance, instead of your healthcare provider looking to you, for example, for a 20% out-of-pocket charge for a doctor's visit, that charge may be paid by your Medigap. Plan C and F are off to the side because those plans, they're still around if you were first eligible for Medicare prior to January 1 of 2020. But if you are new to Medicare since then, you can no longer get one of those plans. I'm sometimes asked, well, which is the best plan? I'm never going to tell you a best for anything, but I can tell you that the most comprehensive Medigap that's available for someone newly eligible is a Plan G. Just a reminder, Medigap is supplemental coverage. It's secondary coverage. It is not covering anything that original Medicare doesn't cover. So it's not your solution for routine dental care or vision care. It's not going to pay for long-term care. It's not related to prescription drugs. So just a quick summary. I think of Medicare as driving down a two-lane highway. Lane 1 is original Medicare, where you have Part A and Part B. If you want drug coverage, you get a Part D plan. And if you want to limit some of those A and B out-of-pocket costs, you can purchase a Medigap plan. In Lane 2, you have the Medicare Advantage plan. A managed care plan that's going to include your hospital coverage, your medical insurance. It probably includes drug coverage, but if it doesn't, you are likely able to select a Part D plan. What you can't do in lane 2 is buy a Medigap, and that is because these Advantage plans have an out-of-pocket maximum. Now, every year, there are a number of different enrollment periods that Medicare has, times that you can sign up or times that you can switch your coverage. I don't have the time to get into all of them, but obviously the biggie that we're all in right now is open enrollment. It began October 15th. It goes through December 7th. During this period of time, if you make a change, it's going to be effective January 1 for 2024. This is your chance. If you want to switch from original Medicare to Medicare Advantage, if you want to switch from Medicare Advantage back to original Medicare, if you want to switch Advantage plans, if you want to switch Part D plans, and with certain limitations, if you want to switch Medigap plans, now is your opportunity. So maybe you've been driving along very happily in lane 2 with your Medicare Advantage plan, but this fall you got a new diagnosis and you want to see a new provider, and that provider is not in your plan's network. This is your chance where you can make a change to help you with that situation. One other enrollment period I just want to emphasize is that if you are in a Medicare Advantage plan, that also entitles you to another open enrollment period from January 1 through March 31, but you're limited in that the only changes you can make during that time frame are going back to original Medicare and picking up a Part D plan or switching Advantage plans. I also just want to quickly mention, for those of you who are wondering, where do I get the information about the plans? Like, how do I know what Part D plans I can look at or what Advantage plans? If you have not been on Medicare.gov, it has a very useful tool that we call Plan Finder. You can reach it right from the home page. There's a button that says compare drug and health plans. You get to this screen, you put in your zip code because that is what's going to control which plans are available to you. You can then choose what types of plans you want to compare. So for example, Part D plans. You're then asked a series of questions. If you don't know the answers, you can always say, I don't know. You're asked if you want to see your drug costs. Honestly, unless you don't take any prescription drugs, I never understand not saying yes to this question, because this is what determines what you're going to pay. You're asked to put in information about all the drugs that you take. If you have a My Medicare account, it can be useful to log into it, because then this section will pre-populate with whatever information Medicare already knows about your drugs. You're asked to put in information about some of the pharmacies you like to use so you can comparison shop. And then Plan Finder will show you all of the plans available based on your zip code and a wealth of detail about these plans. If you click the Plan Detail button, you will see price information, you will see tiering information, you will see if a drug is not on a formulary, you'll see drug restrictions. There's a lot of detail here. You can do the same thing with Advantage plans if you prefer to compare those, and you will also get all the same information about the drugs that you see for the Part D plans is in those Advantage plans that have drug coverage. Plus, you'll see other information about the Advantage plan, like additional benefits it offers or what its premium is. Medicare.gov is also where you can start with your research about Medigaps. It's somewhat less comprehensive for these. You enter your zip code, it will give you basic information about what is sold in your state. Medigaps are regulated by state insurance departments. Some of those state insurance department websites have really great Plan Finder type tools for Medigaps. Others don't though, so it's a little bit hit or miss depending on where you live. I also just want to briefly mention, for people who may be struggling with their Medicare costs, there are programs available to help. There are Medicare savings programs, which are actually run by each state's Medicaid offices. There are a number of different types. I'm not going to get into all the detail right now, but these are programs that may be able to help pay for costs related to Medicare Parts A and B. There is also the Extra Help program, or the Low Income Subsidy, which is a federal program that can help with costs of Part D. If you are enrolled in a Medicare savings program, you should be automatically enrolled in Extra Help. But Extra Help, usually the income and the asset limits are higher. or you can have more and still be eligible for extra help. And so if you want to, you can apply directly for this on the Social Security website. In addition, some, not all, but some states have state pharmaceutical assistance programs, which also can help with some of your prescription drug costs. And finally, I'll just throw in, as a reminder, Medicare is not our only public health insurance program. So for some people, they may also be eligible for Medicaid. If they are, Medicare is typically your primary payer, Medicaid is secondary. It acts almost like a Medigap in that regard. So I ran through that. I tried to pack in as much as I could in a limited time, but I will just say, if you are still sort of feeling like you have more questions or you need more support, a few places we suggest going. The Medicare and You book, which if you already have Medicare, you probably have received this fall. It is a good desktop reference and a good first place to look for an answer to a question. And if you don't have a hard copy, it is available online. Obviously, I talked about Plan Finder. You can call 1-800-Medicare, and if you say agent, you can speak to a human being. But what I really want to emphasize on this slide are state health insurance assistance programs, or SHIP programs. Every state has a SHIP program, which has counselors who provide free, impartial information to people with Medicare and to their families or their caregivers. SHIPs can be called different things in different states, just because Medicare wants everything to be as confusing as possible. So like in New York, they're high cap. In California, they're high cap. In Florida, they're shine. You can look up the contact information for your state SHIP program on our Triage Cancer has a state resource pages. But they have counselors who may be able to help you like do a plan finder search, answer questions about plans that are available locally. And what's important is you're not paying for this service, and these are not insurance agents or brokers. And I am very respectful. I know a lot of fantastic insurance agents and brokers who are very knowledgeable. But the one thing we want people to remember is that if you're working with an insurance agent or broker, they are paid, at least in part, by what they are selling. So the SHIP programs are a chance to sort of get that impartial information. You can also go to our website. We have a resource hub with a lot of Medicare-related resources, including the comparison worksheet I mentioned that will walk you through comparing Advantage plans and Medigap plans. We also, if you sort of are really interested in the lengthier version of what I've presented tonight, we recorded a Medicare 101 presentation last month, which is much lengthier, goes into more detail, walks through using the comparison worksheet and Plan Finder with some examples. We have a host of materials on other topics as well. And I will just say, if you sort of are thinking, wow, I have a question and I've already looked through a lot of resources and I can't, you know, I just feel like I'd like to talk to someone, we have a free legal and financial navigation program where we provide free one-on-one help. You can reach out to us if you have a diagnosis. Doesn't have to be cancer. We will talk to, we're happy to talk to anybody. Caregivers, we work with healthcare professionals. There's a link on the website. It's available in English and in Spanish, as is the entire program. You fill out the intake form with your questions. You'll be prompted to schedule a call at a time that works for you. A member of our staff will reach out to you. We'll ask more questions. We'll discuss things. We may have to do some research, schedule a second call, but our goal is to try and help give you accurate information so that you are able to take next steps. And with that, I think I can stop. There we go. Thank you for taking that back.
Thanks, Amanda. And I will call up Dr. John now and Kim Umphres.
Thanks, Amanda. That was fantastic. You obviously had to condense an unbelievable amount of very complex information. I wish I could say that after a half hour I now know everything there is to know about Medicare, but I can see that you were forced to just skim the surface. But the good thing is that you told us how we can get unbiased information when we're really in trouble. Kim, did you want to follow up?
Excuse me?
Did you want to follow up with some words of your own?
Can you hear me okay?
Yes, we can.
Okay, yeah. No,
Tell us
very nice.
who you are and what your knowledge base is and how
Okay,
you can
yeah,
help
well,
us.
thank you for having me here. What I do, I'm a health insurance broker, and my exclusive specialty is in the field of Medicare supplementary and Medicare Advantage plans. I assist my clients with getting a proper prescription drug plan and just generally sitting down and just brainstorming on what their best positioning is, as well as what their options are.
Okay, that it?
Yeah, that's what I do, and yeah, that's what I do. But I was going to mention that the material that Amanda covered was very thorough, to including information about the special programs offered by Medicare and the way to look for supplementary to add your drugs. And that was very excellent. I always encourage everybody to start out by having and creating a Medicare.gov portal as well, with some excellent material. We can go from there. Happy to answer any questions, of course.
I've got a couple of questions sent in to me so far. And then we'll get to our panelists after I ask a couple questions. The first one is from a veteran who has Medicare and TRICARE for life. What should he do? Is there should he look at Medicare Advantage plans, or is he better off sticking with original Medicare plus TRICARE for life? How does TRICARE fit in to all this? Either of you?
Okay, well, my view on that is that, TRICARE for life is basically a Medicare supplement. So it's designed to act as secondary to Medicare as primary, and coupling it or having a Medicare Advantage plan in addition would likely create a conflict with TRICARE. So it would not be recommended, as far as I know. And TRICARE itself, it's an excellent Medicare supplement, full coverage. It kind of mirrors what we used to call a Plan F, which is 100% coverage, paying everything Medicare doesn't pay on Medicare type charges. And it also has the prescription drug benefit that does not include the gap or the donut hole. So it's not only creditable, but it's also superior to Part D coverage that you would get normally. So there's really no reason whatsoever that I'm aware of to interfere with TRICARE with any other supplement, or especially Medicare Advantage.
That's very good, very clear. I'm going to ask one more question, this one for Amanda, and then I'm going to go to some panelists that AnCan has gathered together. This next one, it has to do with switching back and forth between original Medicare plus Medigap and a Medicare Advantage plan. Is it as easy as that? You wait till the enrollment period and then you just push a button and switch? Is there a problem with pre-existing illnesses or other restrictions on switching back and forth?
So the answer to that is yes and no, which I know is like a lawyerly kind of answer, but it is going to depend. It's not so much the switching from original Medicare to Medicare Advantage. That is as easy as, making the phone call during open enrollment and making that change. But whether or not you're going to be able to pick up a Medigap is going to depend. There are periods of time with Medigap that are called guaranteed issue. If you're in a period of time where you have what are called guaranteed issue rates, it means that an insurance company cannot use medical underwriting. An insurance company can't make a decision about whether they're going to sell you a plan or how much they're going to charge you, taking into account your medical history. But periods of time when you have those guaranteed issue rights are limited. The best time to get a Medigap, most people will say, is during your what's called the Medigap open enrollment period, which is the first 6 months that someone is both 65 and has Medicare Part B. Whether or not you can get a Medigap if you're under 65 depends on your state. Some states have rules that make sure their the insurance companies operating in them will sell Medigaps to people who have Medicare on the basis of disability. Others don't have rules like that. And then what you can do with a Medigap during open enrollment is going to vary. So it's not a question I can answer like sort of yes or no, like yes, we're not going to have a problem. It is something to think about, and it's one of, you may have seen it on my chart sort of with pros and cons of Medicare Advantage. One of what I would say is that you potentially may have some issues when you do go to pick up a Medigap.
Thank you. I want to just mention that Alexa has posted the website address for triagecancer.org. Okay, I'm going to start going to the panelists who have some questions for you guys. We have a few panelists. I'm going to start with Jim Schrate. Jim is a member of AnCan, and he's here representing the prostate cancer community. Jim, would you like to ask a question?
Yeah, I had a question about what's the difference in coverage for physician-administered drugs versus prescription drugs, and it comes up in the context of where people have been receiving one therapy by injections at the doctor's office, and then a new drug comes online that has benefits. You know, how do you position yourself so that you can get the best treatment?
So, you know, can I start, Kim, or you wanted to?
Go ahead. Sure.
Okay, so I would say, first of all, how the drug is administered can play into which part of Medicare covers the cost of that drug. So physician-administered drugs typically are going to get covered under Part B, whereas prescription drugs that you are purchasing on your own through a pharmacy are going to be covered under Part D. That's kind of a simplification. There are a lot of other rules that deal with which part of Medicare is covering a drug. In terms of your question about how do you position yourself, I mean, I would view that much more as a medical question. You know, to me, I think you're going to want to go to your healthcare provider to say what is the best course of treatment for whatever I'm dealing with. And you always can find out, right, from Medicare, if you have a question about what your doctor is saying to you, hey, I might put you on X, Y, or Z prescription drug next year, you can always go to Plan Finder during the year to kind of get a sense of what is my plan going to pay for this drug. But I can't say I would position myself to get one kind or the other. To me, the first, the threshold for that is going to be what the doctor is going to be suggesting.
Okay, no, I understand. So the injectables are covered probably under Part B, and the prescription is under Part D. Is that correct? Typically.
Yes, but you also, I mean, depending upon a specific drug, there are some other rules that go into, like, there are some funky kind of exceptions that go on. But yes, the general rule would be if you're getting that drug administered by a healthcare provider in a doctor's office or in a hospital, that's going to be Part B, and a drug that you are picking up a prescription for on your own is Part D.
Okay, thank you.
Kim, anything to add to that?
I know that was a very good explanation. Pretty much, the drug will dictate who's going to pay for it. As Amanda mentioned, if it's like an infusion, in the doctor's office. Normally that would come under Part B, B as in boy, at the 80/20 co-insurance type setup or copay on your Advantage plan. And if it comes under Part D, then of course it's comes under the drug formulary. And all of that, as far as positioning goes, you know, what all you can do is, as Amanda mentioned, is maybe find out ahead of time where it's going to fall. That may have some decision making as far as whether you go Advantage or Medicare supplementary, traditional Medicare, but the drug will dictate who's going to pay for it, Part D or B Medicare.
And how does that work for vaccines? I've been bounced back and forth between the doctor's office and the drugstore for vaccines. Can you explain why and what's going on with that?
Well, my understanding on vaccines, most of them are covered under preventive care, under Medicare, you know, 100%, whether you're on traditional Medicare or Medicare Advantage. Most vaccines seem to be covered. You know, flu vaccines, things of that nature. Maybe some copays for shingles or something of that nature.
Seems to matter whether you're in the doctor's office or the pharmacy, though.
Same thing with infusions in the doctor's office. It may be Part B versus a prescription from the pharmacy would come under the drug plan Part D, generally speaking. And of course, there are some exceptions. I've heard of some prescriptions that a patient will have filled and the doctor will inject them and they come under Part D. So, and that's where positioning can come in. The more you know about the drug in advance, probably the better you can position yourself to some degree.
I think flu, pneumonia, and hepatitis B maybe are the big ones that are covered under Part B. But I think, again, those are all ones where they're going to be administered by someone.
Okay, thank you, guys. Jim, I'm going to ask Sally now. Sally T is our multiple myeloma advocate. Sally, you have a question for our experts?
Hi, this is from the audience, and I don't know which of you, Amanda or Kim, are going to answer it, but how does Medicare and or Medicare Advantage work if you're buying your prescriptions out of Canada?
You want me to take a stab at it first? So look, obviously everybody wants to have prescription drug insurance. It doesn't always mean that purchasing a drug through your insurance is your least expensive way to do that. So there are, even leaving Canada aside, right, there are various drug discount programs run through nonprofits. There's Costco, BJ's, the Cost Plus pharmacy that Mark Cuban does. There are ways that people sometimes find to save money where they feel it is less expensive overall to purchase their drug and not run it through insurance and pay cash. The downside to that is whatever you're paying is not going to count towards satisfying your deductible, or eventually when it starts an out-of-pocket maximum, but maybe you don't care about that if you're saving a tremendous amount of money on the drug. I think that is also why people may turn to a pharmacy that's out of the country. But sort of the easy, fast answer is if the pharmacy you're ordering from is not a pharmacy that your insurance plan works with, they're not going to cover it.
Thank you.
Comments, Kim, to that?
No, that is the way to do it. What I recommend my clients do is once we've performed our due diligence on Medicare.gov, that's our position with Medicare. Then I recommend looking into the other options Amanda mentioned, Mark Cuban, GoodRx, Single Care, Canada. And I will mention though that anytime you use a program, an alternative program like that, as mentioned, it does not go towards your drug plan. It's no part of it. But in some cases, that can actually work for you by not putting you in the donut hole. So the best way to approach your drugs, in my experience, has been with my clients, is do the due diligence on Part D, have your portal set up, and then look at the alternative plans to see if it comes in better with them than the traditional Medicare Part D. At that point, you've probably obtained your drugs at the least possible cost.
Kim, could you give a little bit more clarity, a definition of the donut hole? We did see a graphic of it when Amanda was talking. What's a donut hole?
Yeah, that's an interesting section of Medicare, and I'm pretty familiar with it. I want to look at my notes just so I don't mess it up too bad. Okay, how it works when you have a Part D Medicare drug program, you start out, there's phases. You start out with a deductible. There's a potential deductible. Most Advantage plans don't have them. Many of the traditional Part D plans do. I believe $545 is the new amount for next year. That's phase one, or the beginning phase. Once you've satisfied a deductible, if there is one, then you go to the initial phase, or the copay phase, where you make copays based on your tier levels. Now, once your drugs have reached a retail value, I believe, here is $5,050, right about there. Then you've entered $5,030, pardon me, in 24. Then you've entered the donut hole. Okay, that is where basically the copay and the drug plans kind of go into a gap, a stall. At that point, the drug manufacturer pays 75% of the drug, and the patient pays 25%. Now that continues until the out-of-pocket cost reaches $8,000 and some dollars. I don't have those exact figures. Right about $8,000 in out-of-pocket cost. Then you go to the catastrophic phase where your drug cost should end. Now, the important thing here is understanding how the math works. The $5,030 is based pretty much on retail cost of the drug. Then the getting out of the donut hole, the $8,000 figure, that's based on out-of-pocket cost. But of the $8,000, as Amanda mentioned earlier, and very accurately, you're not paying the entire $8,000 yourself. You're getting credit for what the manufacturer contributed on your part. So that's how it works. You have the deductible, the donut hole based on retail cost, and then the $8,000 figure is based on out-of-pocket cost, getting credit for the manufacturer's contribution. So
Thank you. That's perfectly consistent with what Amanda said. And Amanda, I apologize for having that repeated again, but you didn't use the word donut hole, I don't think. So I wanted to make sure people knew what that was.
I don't use it because even though it does still exist, I want to emphasize to people that from the consumer standpoint, they are consistently paying 25% through that entire initial coverage phase, unless and until they hit catastrophic coverage. It is true that who's paying the balance is switching around, during that phase. But I just find sometimes it's easier to just emphasize what you're paying, and making sure people understand that there's no longer what used to be the case, right, is that there was a period of time where patients were being asked to pay more, and that now that part of the donut hole has been closed.
I'm going to bring on our third panelist, Kim. Kim is a multiple sclerosis advocate. Can you pop on, Kim, please? Oh, no.
This question is from the audience. The question is, I will be 65 in May. I'm already drawing Social Security. Will I automatically be enrolled into Medicare in May, or do I have to enroll now? Thank you.
It's automatic if you're receiving Social Security. You'll receive a Social Security card probably about 90 days in advance and just make sure Part A and B is on there, and you're good to go.
Thank
That
you.
was quick. Kim, want to ask another one?
Sure. This is a personal question of mine. When it comes to comparing Medicare A and B versus Advantage, one of the things that always my personal fear with Advantage is HMOs, because I like to get my care out of state because I am a huge fan of the Mayo Clinic, which is not in my state. So do you recommend people that tend to travel or be snowbirds that don't live in the same place all year round, or like to get their care outside of their state, to steer away from the Advantage program and stick with Medicare A and B?
I mean, I'll start with that and say, yes, I think that's a smart way to go. If you are a snowbird, if you are someone who knows that you want to be treated out of state, in particular at some of those major, like definitely the major cancer centers. I can't speak to like any one of them in particular with what insurance plans they take, but it is not uncommon when I am talking to someone who, like, there's a few centers that people call from all over the country saying, well, I want to be treated here and only here. And a number of those, they all take Medicare. They don't all take Medicare Advantage plans, or they may be limited in which ones they take. So you just have to be, like, I'm never going to say always do this, always don't do that. You know, like it's an individualized process, but it is something to be very attuned to if you are, you know, if you're partial to getting your care in a particular place.
Could I add to that as well?
Please.
Yeah, that's the question I get a lot of, and it's a big one. It's a big decision to make. And in a situation, I deal with a lot of special needs. So in a case where there's a high utilization rate of care and a person is just starting Medicare and they go, which direction should I go? You know, after we talk about it, and I like to hear everything, we normally recommend start with Medicare supplement. In a nutshell, a 65-year-old would spend maybe $125 to $130 a month for a Medicare supplement. Then you end up with full coverage with about a $250 deductible. You go to the Mayo Clinic, MD Anderson scripts, anywhere you go, you leave your checkbook in the car, you don't pay anything. That's very, very important. Also, now with the Medicare Advantage plans, they do have the maximum out of pocket. So there's a safety gap, not a problem there. And with a good PPO, you should be able to not have a problem with providers. But you can have a problem with providers. But even if you don't, with Medicare Advantage plans, keep in mind that there's pre-authorization. There's other forms of managed care that can interfere with a person's choice, especially if they, again, have a chronic condition or a high utilization rate. I don't know of a real reason to go with Medicare Advantage in that situation unless there's a big difference with drugs. You know, I always say throw the drugs into the mix. It can be a part of your decision making, but Medicare supplement in situations like what you've mentioned is probably the way to go, and you always can go to Medicare Advantage next year.
Sounds like if you want to keep your options open, the best way is to stay on Medicare A and B and not do Advantage.
Well, it's position A, most comprehensive, but having said that, about half my clientele is Medicare Advantage. And at that point, we are very careful. We pick the right plan, the best we can do, remain as independent as possible, and both can work. But in situations with chronic cases, if we can put Medicare primary with a supplemental plan, is probably better.
Thank
Kim,
you very
you
much.
mentioned the pre-authorization question. And from the user's point of view, and you know, many of us are on very exotic drugs. Do you think, or need very exotic surgeries? Do you think that pre-authorization, from the user's point of view, is more difficult with Medicare Advantage than with original Medicare?
I do, yes. You know, with Medicare Advantage, there's another layer of bureaucracy. And I mean nothing negative by that. It's just a fact of the matter. So if you can just have a supplemental plan, you're going to be playing by Medicare's rules. They also have rules, but the book is about half as thick.
John,
Jim, would you like to
can I ask
come
a
in now? By the
follow-on
way,
question to Kim's question?
let me just say, by the way, panelists, when you're not asking a question, it would be great for you to stay. Keep your pictures up on the screen for everyone, and if you don't want to, you don't have to. So your choice. Go ahead, Jim. I'm sorry.
I just wanted to clarify. I thought, Amanda, I heard you say that in a typical Medicare Advantage plan, if you get care out of network, all of that is not included in the maximum out of pocket. Is that correct? Or
Yeah, I don't believe I said that. If you have an Advantage plan that offers out of network coverage as well, there may be a separate out of pocket maximum for those out of network services. The maximum out of pocket number that I gave, I believe I said $88.50 for next year, that is just the maximum out of pocket for covered in network services. So you'd have to look separately to see what the parameters are around that.
okay, thank you.
I've got a question. We had a question of switching from Medicare to Medicare Advantage, and I see the question has come back at me again, but can you switch back again to Medicare from Medicare Advantage? And Amanda, when you had that graphic of the road, the two different roads next to each other, I think you had cars going both ways, didn't you?
I did. You can, so the great thing about, or to me, I feel like I talk to people all the time about Medicare, and I hear a lot of like, it's confusing or scary or complicated, and I agree with all of those things. But at the same time, it's also really good health insurance coverage, and it preserves this ability at least once a year during the annual open enrollment period to make those changes. So yes, you can go back and forth. I mentioned in response to one of your questions earlier, there can be some issues with the Medigap's, and some of those may be different state to state. But yes, your ability to make changes to Medicare, you keep that ability every year during the annual fall open enrollment. And then if your circumstances give you a special enrollment period, like there may be other opportunities that individuals have, but the fall open enrollment is for everybody.
You just have to wait for the proper enrollment period to do that, unless
Right.
you have
Can I
a
mention
special.
something in there as well? Amanda mentioned all these enrollment periods, and that's very important what she mentions, because there's also the enrollment period in January, February, and March. In addition to that, there's about 50 special election periods that allow a person to change plans, come off, go on to Medicare, things of that nature throughout the year, aside from open enrollment. Very, very creative ways to do what Amanda mentioned very much. All year
Sally?
long.
Sally, got another one for us? Sally?
Sorry, I couldn't get the mute button off.
You'll go mute. Oh, okay, very good. Go ahead.
No, I did not have another question.
Okay, how about you, Kim? Kim Stroh. Sorry.
Okay, so with my disease state, multiple sclerosis, we're on really expensive drugs. So my infusion, I get twice a year. One infusion out of pocket is $135,000, what they currently charge me on my thing. I do not pay that amount. I'd have to pay out of pocket currently was for me $4,000 a year. I used to get a patient assistance program that would bring that down quite a bit. Now that I have Medicare, a lot of people don't understand you're not eligible for the patient assistance program. You're eligible to get free drug, but not the eligibility. So can you talk about how, and I've worked in the pharmacy and people be confused that they used to give them the little coupons going, hey, you can get this for $40. Like, you're on Medicare, that's illegal. So do you want to talk about, because people get really freaked out about like that they might be on the hook more for that medication that before they had a nice little chunk of it taken away for their out of pocket that their insurance told them they had to pay for, but then the drug company would pick it up. But that doesn't work on Medicare, or that's how I'm familiar with it.
Can either of you untangle that for us?
I
Amanda?
I can certainly just start by saying that is an issue that I see people encountering, that, you know, the pharmaceutical companies have the rules they follow to offer whatever types of, I'm going to just say patient assistance to encompass, whether that's cash assistance, whether that's free drug samples, you know, however they're providing it to their patients, they have rules about which programs, which people are eligible for. And it is the case that a lot of those programs, there are rules that say if you have coverage under Medicare, they're not going to offer certain types of assistance. You know, there's nothing really to be done about that other than to make people aware that if they are enrolled in these programs, to understand what the rules are, and if the rules are going to change when they get into Medicare, to kind of find out what is the, you know, like it doesn't change the fact you're still looking once you're in Medicare, what is the best coverage I can get, and is there any other assistance for someone who is still going to have those super high costs? There may be other private, for example, private foundations that offer different types of assistance. We do a lot of, or we answer a lot of calls about financial assistance generally, and one of the places that I direct people is to look and see if there are private foundations that may have, you know, support that's available for people if they are finding themselves in a situation where they have been relying on money coming from one of the pharma companies that unfortunately is now no longer an option for them.
Thank you.
Here's a question that came in. If I am covered by my partner's Kaiser retirement plan, and I'm not quite sure what's meant by a Kaiser retirement plan, does Kaiser have a Medicare Advantage plan? I don't know what they mean by a Kaiser retirement plan, but I wish to see doctors outside of Kaiser. Should I get my own Medicare?
So I don't know if Kim wants to speak to this at all. My experience with Kaiser is Kaiser likes to sort of, you know, they offer insurance plans, and then they would like you to get all of your care within the Pfizer system. And I have seen people, like I see it go both ways. There are some people who are very happy with that. And then there are people who, you know, if they want to be out of the Pfizer world, there are challenges to it. I don't know, going back to the beginning of when you were reading the question, I was unclear on whether when the person says their Kaiser retirement plan, if they mean retiree coverage because someone was employed by Pfizer. I mean, I could say a couple of things to keep in mind. One is if you have retiree coverage, either your own or through a spouse, Medicare is always going to be primary to the retiree coverage. And the other thing I would just highlight is be really careful for anybody who has access to retiree coverage. Unlike Medicare, where every year we talked about like you can make changes, a lot of times if you give up retiree coverage, there's no mechanism to get it back. It doesn't mean you should stay with it if it doesn't work for you, but just be aware, a lot of times once you make a decision to forego that, you cannot then change your mind later on.
I know that was the case with my insurance. Sally, you just got a question sent in to you?
Yes, I did. This is a question from the audience. If under the care for cancer, how long do you have to wait before changing plans? I understand that one has to be cleared for 2 years before changing plans.
That might be, you're referring to purchasing insurance after being cancer-free?
I don't know any more than what I just read you.
Okay. Well, it sounds like somebody's asking a question of If I want to purchase insurance, maybe Medicare supplement, am I able to do so after having had cancer? And if so, must I be in remission? And if so, for how long? If that's the question, then generally speaking, 2 to 3 years, sometimes 5, that a Medicare supplement may ask you medical questions before purchasing their plan. Medicare supplements require medical underwriting. So, and that kind of goes back to when you're going back to Medicare versus Advantage plan, you better make sure you can get a supplement first. But in reference to that, that's what they're probably asking about. And it's probably 2 to 3 to 5 years to get a supplement. Now, if you're going for a Medicare Advantage plan, then it's not a concern. There are no medical questions there. They're getting a supplement 2 to 3 to 5 years, depending upon the company, cancer-free.
Could
Thank you.
that be true for a new person, not somebody switching, but somebody just coming into Medicare age who already has a cancer diagnosis? Might they have a hard time getting a supplement plan?
No, not at all. And that's a very good question to make a distinction on, is that's your initial period when you come on to Medicare. There are no health questions asked for Medicare supplement. You can get any plan you want from any company, and it'll cover you immediately with no waiting periods either for pre-existing conditions. And that kind of goes to Kim Stroh's question in regards to a situation of coming on with a condition like that. That'd be a good time to get a supplement, and you cannot be turned down. And you can't be rated up either. It'd be preferred rates with whichever company you choose.
Don, I have another one.
Oh, I'm sorry. Can I just add one thing to what Kim said? It can also vary if you are, again, I only mentioned them sort of briefly, but there are periods of time where people have guaranteed issue rights beyond just the initial 6-month Medigap open enrollment period. And the other way that can differ is by state. There are a couple of states that have continuous guaranteed issue rights. New York, for example, is one of them. A Medigap could still impose a pre-existing condition waiting period for up to 6 months, but you can have those 6 months reduced depending upon whether you have other creditable coverage. So there's no like sort of quick way to confirm for the person who asked this question, but just it can matter sort of whether you fit into one of those guaranteed issue rights circumstances, and it can matter where you are.
And just to clarify terms, when you say Medigap and when you say supplement, you're using these words synonymously?
Yeah, I'm sorry, I wasn't focused on which of the terms you used first, but yes, a Medigap and a Medicare supplement are the same thing.
Jim, do you have what question from your group? You're muted, Jim.
Sorry about that. I have a question from the audience. There's a person who's paying the Part B premium, which is about $174 a month, and he or she has experienced a dramatic drop in income. Is there any way to go back and get that premium reduced, or are there other resources that might be available to help?
That person could see, so they're paying, right now they're paying more than well, I guess you don't know, it's from the question, but if you are paying the basic Part B premium, if you're not paying what's called an IRMA, meaning your higher income and then had a reduction, if you need help with paying the Part B premium, you could see if you're eligible in your state for a Medicare savings program that would help pay that cost. It's going to depend on what the person's income is and potentially what kind of assets they have. Again, that's another example like Medigap where the rules can differ state to state. If somebody is paying an increased Part B premium with an IRMA, meaning they have something added on to the standard premium, if that is the situation and they experience a change in income, they can go back and ask, and indicate that there's been a change in circumstance and see if that results in a treatment.
If I can add to that, just one thing is that in a situation like that, it would be recommended to contact your state agency and or Social Security, because they'll help you get into the medical savings programs. And if your income is, for an individual is, teetering below $1,200–1,300 a month, you likely fit into one of those categories. It is very important to check on that because it's not automatic. You don't automatically get put on extra help or QMB in many cases. So yeah, by all means, it's worth checking with Social Security.
Just to clarify though, Social Security can help you with extra help. A Medicare savings program, you have to go to your state or your county's Medicaid office. Yeah. That's who's gonna make that evaluation.
That's what I was going to ask Kim. When you said your state agency, what agency did you mean?
Well, it can be Medicaid. It can be your state agency, like your Access or Medicaid program or your Council on Aging. They will all direct you to the right agency depending upon what program you're trying to enroll in. As Amanda mentioned, it's one agency is different for the extra help as would be for medical savings programs.
And your SHIP program also, if you, sometimes the SHIPs are run through, as Kim was saying, like your area agency on aging or council on aging, but hopefully they would also be able to point you in the right direction.
Right.
Here's Don, a question. Okay, let me just ask this one. Here's a question about timing. I will be 65 in May, but I'm already drawing Social Security. Does that mean I'll automatically be enrolled into Medicare in May, or do I have to enroll now?
Automatic. If the person's receiving a Social Security income, they'll receive the Medicare card, enrolling them in A and B automatically, approximately 90 days before their the first of the month of their birthday.
And what happens with their premium? For Part B?
They'll automatically be charged the Part B premium, and it'll be
subtracted off their Social Security, right?
Correct. It'll take automatically out of that the amount of less or more depending upon their income. The basic amount they'll start with and go from there out of their Social Security. Correct.
What do you got, Sally?
An audience question. How does Medicare work for people who are over 70 and still working full-time with private insurance?
So Medicare has a lot of rules that are called coordination of benefit rules, meaning who pays first, who pays second. If you are eligible, whether or not Medicare is your primary insurance depends on two things. It depends on how it is someone is eligible for Medicare in the first place. And then it also depends on the size of their employer. So for someone who's 70, they are Medicare eligible due to age. If they work for what is thought of as a small employer, Medicare is primary. That means an employer with under 20 employees. If they work for a large employer, 20 or more employees, then the employer-sponsored coverage is primary and Medicare is secondary.
Thank you.
Jim, do you have anything else? You're muted.
Okay, I was curious, in the prostate cancer world, we have a lot of new drugs coming online every year. If you start out a year and a new drug that's approved is not in the formulary, is there a process by which the insurers typically add these drugs, or are you just out of luck for that year?
Want me to take it?
Yeah, you can go.
Okay. Sure. Well, once you perform the due diligence process and you signed up for a Part D plan, you may have new drugs coming in January, February, June, or whatnot, and those drugs will be covered. They'll just fall into whatever category they'll fall into, and they should be covered. Specifically, what was the question on how they'd be paid?
No, it's when they would become covered. If you start the year, they're not in the formulary, and they're approved during that year. Do they typically bring them into the formulary during the course of the year, or are you just outside of coverage for the entire year? Is there a typical way it works?
Well, okay, there's how Medicare works with the drugs in the formulary. Typically, there's 2 drugs in each category. That's what Medicare requires. So if a new drug comes out, if it's not in the formulary, as far as I know, the 2 ways to approach that, one would be a formulary exception. You contact the drug plan for that, for a formulary exception, and that likely could bring the drug in. And if it's a specialty drug at a very high tier, it can also be re-tiered to a lower tier by contacting the drug company. But a new drug coming in, if it's not experimental, normally we see them being covered, but there are some drugs that aren't covered. And in that case, they need to be addressed individually. And there's different ways of approaching them through the manufacturer, formulary exceptions, and if they're going to cover them, re-tiering them. It becomes very individual at that point. And Amanda probably could add more to that, I'm sure.
Yeah, Amanda, did you want to add more to that?
No, I mean, Kim addressed it. I would say that's an example of a situation where it can be worthwhile to reach out to the drug manufacturer. A lot of times, Kim, the other Kim brought up patient assistance programs earlier. Sometimes those patient assistance programs, the people there, can be helpful with other things besides just the financial help. And one of them we have found is giving information to people about, like, how do you get a brand exception or a tiering exception? How do I appeal if I've been denied this drug, right? Like, they are seeing the same types of things happen over and over again for the same drug, whereas for the individual, this is probably their first experience with this. So that just, I'm just sort of throwing it in there as another avenue to go down to try and get some support for getting coverage.
Alexa, would you pop on for a moment?
I've been summoned.
Hi, Alexa.
Yes, of course.
You've been summoned from the undead. How much time do you need to wind things up?
I only need about 2 minutes.
2 minutes? Okay. Kim, do you have a last question? Kim Stroh?
I will ask the audience question here. It is, I take an oral chemo drug that lists for greater than $20,000 a month. How does out-of-pocket calculate with Medicare Part D coverage?
Go ahead, Amanda.
It doesn't.
Who wants to touch that one?
So again, it wouldn't be any different than it's calculated for everybody else. So through this year, right, even once you entered with those kinds of costs, right, you were hitting that total out-of-pocket cost. This year, I think, was in the 7,400 range. I don't remember the exact number. And at that point, you were responsible for 5%. But beginning in 2024, the good news is that 5% coinsurance is going away. So once the total out-of-pocket costs for that drug are hitting $8,000, I'm assuming it's a drug covered under Part D, the individual will no longer have responsibility paying for that drug. And then starting in 2025, there'll be a true out-of-pocket cap at $2,000. And again, the $8,000 out-of-pocket maximum, it's not just what it doesn't mean that you yourself have made an $8,000 payment. It's that between what you have been responsible for and any required drug company discounts, further to Kim's discussion, the other Kim's discussion of the donut hole earlier. So the reality is it probably looks like, I think I've seen some estimates that it's more like the individual is paying around $3,400. Don't quote me on that amount, but I think for brand names, it's saying that's around what the individual's exposure is before they hit catastrophic coverage, at which point they're no longer going to be responsible for a co-insurance.
I'm going to thank you guys all very, very much and turn things over to Alexa for winding things up.
Of course. Oh my gosh, Amanda and Kim and our patient panel of Kim, Jim, and Sally, thank you guys so much. This was super informative, great way to answer questions. Loved it. And we got already a lot of great audience feedback. And I know people are going to be wanting to watch the recording too. I want to give a big thank you once again to our sponsors. A huge thank you to Triage Cancer. Amanda's been so generous to create a sheet that I have put in the chat, and we will send to you as a follow-up of, you know, what you can do to get help. And of course, you can always go to triagecancer.org/get-help to get even more help. And Amanda, there's so many good resources on the Triage Cancer website, and you guys are incredible. Just on a personal note, I got to meet Monica of Triage Cancer in person, the first time I've ever met someone in person before we did a webinar, and I got to meet her whole family, and they're just so precious, and her kids are super passionate about people being empowered patients, and I love that. So I want to give a big shout out to Monica and her family. But at AnCan, we love to support you. We truly believe in you being your own best advocate. We have several fabulous groups. We have a group nearly every night of the week. So check us out at ancan.org/groups. And of course, we have great things like Solar Teal and art classes and everything. And so please, we will be sending you emails, but please get in touch with us, get in touch with Triage, and we will be having a follow-up survey too. So let us know what you think. And with that, I wish you a good night and happy Halloween. Good night,
Good night, everyone.
Good night.
Good night.
Good night.